Module 7, the child with a sensory or neurological disorder. The nervous system is going to be immature at birth, and growth and development will occur as that gross and fine motor skills begin to develop. The sensory organs include the eyes and the ears. At birth, newborns really don't focus clearly, but by 2 months, they can focus and follow objects with their eyes. And by 7 months, they have depth perception maturing. Their visual acuity is usually between 2100 and 2400 until they're about 5 years of age, which at that time, most of them have 20/20 vision. Their first hearing screening will be completed before the newborn is discharged from the hospital. Infants will respond to sound within the first month of life. With vision impairment, vision does affect their learning processes, their social development, and coordination and safety. Refractive errors will include myopia, which is the nearsightedness, hyperopia, which is the farsightedness, astigmatism, which is the unequal curvature in the cornea that bends light rays in different directions. Blindness is legally defined as corrected vision of 2200 or less, or peripheral vision of less than 20 degrees in the better eye. It can be caused by maternal infections. It can seriously hamper the child's ability to form human attachments, learn coordination, balance, and locomotion, and distinguish reality from fantasy. How they interpret the surrounding world. Children that have partially sighted or blind vision, they really do well among normally sighted children. It is necessary for us to provide specialized equipment for these kids and understand that they have the same needs as other children. They require emotional comfort and sensory stimulation, which is communicated through touch, sound, and smell. So we have to allow the child to touch items. Identify yourself when you enter the room and encourage the child to be as independent as possible. Development can be moderately to severely impaired in the hearing impaired child. It affects their development of speech and human relationships, and their understanding of their environment all depend on hearing. Chronic middle ear infections can destroy part of the eardrum or ossicles. The profoundly deaf is more likely to be diagnosed before the age of 1. Deafness, intellectual disability, autism are sometimes incorrectly diagnosed because they can all have similar symptoms. There are special preschools available for deaf children, and the federal law does require free and appropriate education for all disabled children. So when they're in the healthcare facility, encourage the primary caregiver to be present to help the child with communication. Stand or sit face-to-face on the child's level when speaking to the child, and be certain the child can see you before you touch them. Demonstrate each procedure before it's performed and keep a night light on in the child's room. Strabismus is the failure of the two eyes to direct their gaze at the same object at the same time. It can also be called the squint or cross eyes. This can result in diplopia or double vision. Then the central nervous system can actually suppress vision in the deviant eye, causing amblyopia or the lazy eye, which leads to dimness of the vision from disuse of the eye. So we have a wide variation. monocular strabismus, estropia, extropia. The treatment will depend on the type. It may involve patching of the eye, glasses or orthoptics, or surgery. Early detection and treatment is essential for successful outcomes. Otitis media is one of the most common infectious diseases, especially in children. It's related to the eustachian tube being shorter, wider, and straighter, frequently caused by Haemophilus influenzae and the Streptococcus pneumonia. Uh, Infant immunizations have decreased the incidence of otitis media, but these infants will be restless. They'll repeatedly shake their head. They'll rub or pull at their ear, and older children will complain of pain, fever, irritability. They may have decreased activity, lack of appetite, hearing impairment, possibly even vomiting or diarrhea. We diagnose by looking in their ear, and we see that bright red, bulging eardrum. Spontaneous rupture can occur, followed by purulent drainage and relieved pain. Acute cases we treat with antibiotics and analgesics or antipyretics. Chronic cases may require prophylactic courses of antibiotics, meningotomy, which is the tubes. Possible complications would include mastoiditis. So it's really important to teach about prevention of otitis media and the care of the child if they are infected. Otitis externa is an inflammation of the tissue in the external auditory canal. The inflammation is usually caused by an overgrowth of pathogens or a fungus and usually is post-trauma. That growth of those pathogens is supported by retained moisture from swimming. And that's why we call this the swimmer's ear. Another possibility is that there was a hair follicle that became infected, causing a furuncle or an abscess to develop. Or skin conditions such as psoriasis or eczema can also lead to otitis externa, along with seborrheic dermatitis or allergies to different hair products can also cause dermatitis that lead to otitis externa. So with these kids, the tissue in the external ear looks red. There might be swelling, and in fact, there can be so much swelling that the actual canal swells shut. There is discomfort that increases with the manipulation of the ear during examination. Their hearing, of course, is going to be reduced because of that swelling. In severe infections, they may have a fever and the lymph nodes behind the ear might enlarge. Otoscopic examination will reveal diffuse or confined inflammation, swelling, and pus. A culture of the drainage will help identify that specific pathogen. So we can apply warm soaks, analgesics, and antibiotic ear medication, often with corticosteroid medication in the eardrop. It's important to advise swimmers to wear soft plastic earplugs to help prevent trapping water in the ear. If chewing produces or exacerbates discomfort in the ear, the nurse should encourage the child to temporarily eat soft foods or just consume nourishing liquids. And then we need to teach about prevention. So they should never use cotton swabs or other objects such as hairpins, matchsticks, or keys, anything that can cause trauma to the external auditory canal. They should avoid swimming in polluted water and dry the outer ear and external auditory canal after the ears are immersed in water. And if water seems to stay in the ear, try using a blow dryer on a low setting to help dry up that moisture. Chronic serous otitis media can destroy part of the eardrum or the ossicles. What does this lead to? Is this mixed hearing loss, sensorineural hearing loss, conductive hearing loss, or central auditory dysfunction? This is going to be the conductive hearing loss. Acute or non-recurrent seizures. A seizure is a convulsion, and it may be a symptom of a wide variety of disorders. We may see febrile seizures, which are really most common, and they usually occur in the form of a generalized seizure early in the course of a fever. It's commonly associated with temperatures of 102 to 106. Some uh, children may convulse with a fever of just 100 to 102 degrees. Often it's one of the initial symptoms of an acute infection. Less common causes include intracranial infections, toxic reactions to certain drugs and minerals, metabolic disorders, head trauma, and various brain disorders. So these seizures occur suddenly without warning. We see restlessness and irritability that may precede the episode. The body stiffens, there's a change in the level of consciousness. We see those clonic movements occur, irregular breathing, and the ability to swallow saliva. So very important to protect the child from the seizure, making sure they're not injuring themselves. We may administer IV diazepam or lorazepam and give acetaminophen for a fever. Seizures are also referred to as convulsive disorders, and they can be a result of a variety of causes. Epilepsy is recurrent and chronic seizure disorder, and it can be classified as primary, which is the most common, or secondary, which results from infection, head trauma, hemorrhage, tumor, or other organic or degenerative factors. These clients often have a focal onset or the partial onset seizure that begins in a particular area of the brain. The generalized onset will involve both hemispheres of the brain. The unknown onset, we don't know where the beginning of the seizure occurs. The International League Against Epilepsy has new terms to describe and classify seizures. So the focal onset, uh, where seizures, the child is awake and aware during the seizure. The focal onset motor seizure will cause localized motor activity, which is limited to one side of the body or may spread to other parts of the body. The focal onset sensory seizure may include sensory symptoms, including that aura, which happens prior to the onset of the seizure, and it can involve sight, sound, taste, smell, or touch, and even emotions. The child may even have numbness, tingling, paresthesia, or pain prior to the seizure. The focal onset impaired aware seizures, the child is confused or awareness is affected during the seizure, but they're unable to respond normally. That seizure begins in a small area of the brain and changes consciousness. We see motor and non-motor symptoms, non-purposeful movement, and repetitive actions. After the seizure, the child may be confused or go to sleep, and often they're unaware they had a seizure. The generalized onset seizure, both sides or hemispheres of the brain are affected at the same time, where we see the tonic-clonic, the absence, atonic, myoclonic, Infant spasms, seizures. With the tonic-clonic, there's 4 stages. We have prodromal, tonic phase, clonic phase, and the postictal period. With the absence seizures, basically conversation might be interrupted or physical activity might be interrupted. The child kind of loses awareness and stares straight ahead, and you might see some muscle twitching, but you might not. After the seizure, the client is immediately alert and continues a conversation, unaware of what actually happened. With atonic seizures, we have a sudden momentary loss of consciousness, muscle tone, and postural control that results in a fall and possible injuries. With myoclonic seizures, we see a sudden jerking of muscles or a group of muscles, often in the arms and the legs, without loss of consciousness. It occurs early in the stages of falling asleep. And then we have infantile spasms, which are more common in children that are younger than 2 years of age. We see the flexion or extension of the arm, leg, or head, often preceded or followed by crying. Muscle contractions are sudden, brief, symmetrical. They're accompanied by rolling eyes. Loss of consciousness does not always occur in these situations, and it almost always indicates a cerebral defect. There is a poor prognosis with these kids despite treatment. And then status epilepticus is a seizure that lasts longer than 30 minutes or is a series of seizures in which the child does not return to the previous normal level of consciousness. Immediate treatment will decrease the likelihood of permanent brain injury, respiratory failure, or even death. It is an emergent situation requiring immediate treatment. We treat it with diazepam and lorazepam. We can give that rectally or IV. We diagnose seizures with EEGs, video and ambulatory EEG, skull x-rays, CT, MRI, brain scans, physical and neurological assessments, and seizure history. We treat it with anticonvulsant drug therapy. If you look at table 35.1 in your textbook, you'll see several of these drugs. We can also do surgery or a vagus nerve stimulation, and ketogenic diets have been shown to be helpful. So during a seizure, it's important to keep that child safe and help prevent any injury. Provide the child and the family with complete and accurate information. Certain limits and restrictions might be necessary to help prevent further injury. You are the emergency department nurse who's admitting a 6-year-old male client who's come in by ambulance from a school. The paramedics inform you that the child has been having repeated seizures for about 35 minutes. What drug would you expect the healthcare provider to order? IV Dilantin, IV Solumedrol, IV morphine, or IV diazepam? We will give IV diazepam. Meningitis. This is an infection and inflammation of the meninges, or the membranes that surround the brain and the spinal cord. We have viral meningitis, which is referred to as aseptic meningitis. The symptoms, excuse me, are very similar to bacterial meningitis, but it's not as severe. Causes can be from a variety of viruses that often enter the body through infection in the nose or the mouth, with the enteroviruses being the most common cause. With bacterial meningitis, this is frequently caused by the Streptococcus pneumoniae, the group B Streptococcus, Neisseria meningitidis, and Haemophilus influenzae. Transmission of this bacteria will vary. It may be through droplet or through the bloodstream from infection elsewhere. So standard precautions and droplet transmission precautions will be necessary. The Hib and pneumococcal conjugate vaccines have decreased the incidence of infections, but they still happen. We also have vaccines for meningitis. The onset of meningitis can be gradual or it can be abrupt. In infants, we see fever. We may see the bulging fontanelle, poor sucking and feeding, lethargy, and irritability. In the older child, we may see headache, nuchal rigidity, the arching of the back, or the positive Koenig sign, where we have pain along the vertebral column or an inability to extend the knee, or the positive Brudzinski sign, which is resistance or pain felt when the chin is tipped towards the chest. Photophobia, nausea, vomiting, and confusion. These kids may also develop generalized seizures and can go into a coma. Meningococcal meningitis, we see petechiae and purpuric rashes. We diagnose this through lumbar puncture before antibiotics are given, and we measure the spinal pressure and check spinal fluid for white blood cells, protein, glucose. We're looking at the fluid to see if it's clear or purulent, and we can also send it for a gram stain. Make sure that you're using appropriate transmission precautions, IV antibiotics and steroids, antipyretics, and anticonvulsants. If there is a subdural effusion along with the meningitis, we need to aspirate that, and it may require repetitive aspirations. Prevent complications such as deafness, intellectual disability, seizure disorders, hydrocephalus, and paralysis. Cerebral palsy is a group of disorders that arise from the malfunction of the motor centers and the neural pathways in the brain. One of the most complex of common permanent disabling conditions is cerebral palsy. It is often accompanied by seizures, intellectual disability, sensory defects, and behavior disorders. Prenatally, it can be caused by any process that interferes with the oxygen supply to the brain, maternal infection, nutritional deficiencies, kernicterus, and teratogenic factors. Perinatal causes may include prematurity because of immature blood vessels that predispose the neonate to cerebral hemorrhage, anoxia immediately before, during, or after birth, intracranial bleeding, asphyxia, maternal analgesia that depresses the respiratory center, and birth trauma. With postnatal causes, it can be head trauma, infection, neoplasms, or even a stroke. It's really important to prevent these things from happening because it can actually cause irreversible brain damage. Prenatal care should be done to help improve nutrition, prevent infection, and decrease the incidence of prematurity. Perinatal monitoring is done to prevent trauma. Postnatal prevention of infection is initiated. Protection of trauma from motor vehicle accident, child abuse, and other accidents should also be instituted. So there's different types of cerebral palsy and different manifestations with the different types. But we see difficulty controlling voluntary muscle movements, seizures. There may be intellectual disability, hearing and vision impairments, behavior disorders, delayed gross motor development, abnormal motor performance, abnormal postures, and persistence of primitive reflexes. Diagnosis will seldom occur before 2 months of age, and that may be delayed until the second or third year when the child begins to try to walk. Diagnosis will be based on observations of delayed growth and development. So the major types of cerebral palsy includes the spastic type, in which we have the hyperactive stretch reflex in associated muscle groups. We may have increased activity of deep tendon reflexes and clonus, contractures that affect the extensor muscles, and we see scissoring. When the child is standing, they're on their toes, and it makes it very difficult to walk or run. The athetoid type or dyskinetic type, we see involuntary, uncoordinated motion with varying degrees of muscle tension. They're constantly in motion, and their whole body is a state of slow, writhing muscle contractions whenever voluntary movement is attempted. We may see a lot of facial grimacing, poor swallowing, tongue movements that cause drooling or dysarthria. These kids have an average or above average intelligence, and hearing loss is common. With the ataxic type, we see a lack of coordination caused by disturbances in the kinesthetic and balance senses. It is the least common type and may not be diagnosed until the child starts to walk. The gait can be awkward and wide-based. We may see a mixed type where we have signs of more than one type of cerebral palsy. Usually these kids are going to be severely disabled and is often caused by postnatal injury. So diagnosis is made through the birth and family history. Again, may not be diagnosed until the child starts to walk. They may show signs of intellectual disability, attention deficit disorder, or recurrent seizures. We may see developmental delays in screening. MRIs, cranial ultrasound can also help determine the cause in infants before the closure of cranial sutures. Treatment and special aids are going to help the child make the best use of their residual abilities and achieve the maximum satisfaction and enrichment in life. A team of healthcare professionals will work with the family to help set realistic goals. Different medications might be given to help with all of the issues these children face. Physical therapy will help teach the ADLs and various techniques that are used. Orthopedic management can include braces and other orthopedic devices used as supportive and control measures. And surgery sometimes can improve function and correct deformities. There are technological aids for daily living, where we see biomedical engineering perfecting a number of devices. The motorized wheelchairs, the completely electronic cottages with voice-activated computer systems, special chairs and special feeding aids, dishes, silverware, games, computer programs that can help aid in communication. Nurses need to interview and observe the child and the family to help determine the needs and the level of development, the stage of family acceptance, and help them set realistic goals. We should encourage the child to maintain their current self-care activities and set goals for attaining new ones, and provide appropriate pre- and postoperative care when surgery is needed, and provide necessary support to help the child and the family deal with complex situations. These are some of the aids that might be used. True or false? Moderate technology has greatly improved the life of the child with cerebral palsy. This is true. And Down syndrome. This is the most common chromosomal anomaly. We see 1 in 700 to 800 births. They may also have trisomy 21. It is a higher risk of a Down's child for women that are older than 35 years, but it can be born to women of all ages. There are various screenings that can be done during pregnancy with blood tests and ultrasound to detect the possibility of the Down syndrome before delivery. Clinical manifestations will include brachycephaly, short stature, the upward and outward slanted eyes with the epicanthic fold at the inner angle, the short flattened bridge of the nose, the thick fissured protruding tongue, dry cracked fissured skin that might be mottled. Their hands are small with short broad fingers and a curved fifth finger. They have a single deep crease on the palm of the hand, and there's a wide space between the first and second toes. They have a very lax muscle tone. They have heart and eye anomalies and a greater susceptibility to leukemia. Treatment and nursing care. Well, their physical characteristics will determine medical and nursing management. Respiratory difficulties, late motor development, GI tract issues, congenital heart defects, vision or hearing problems, and difficulty eating. These families require strong support and education. There are intervention programs available. With Down's syndrome, difficult decisions might be necessary. And finally, we have anencephaly. This is a serious birth defect in which the baby is born with an underdeveloped brain and incomplete skull. It's a type of neural tube defect, and as the neural tube forms and closes, it helps form the baby's brain and skull, which is the upper part of the neural tube, the spinal cord, and the backbones, which is the lower part of the neural tube. This is a fatal condition with a very poor outlook. Most fetuses with anencephaly will pass away before birth and the pregnancy will end in miscarriage. But if a baby is born with an undeveloped brain or underdeveloped brain and an incomplete skull, that baby might be stillborn or usually will only survive a few hours to a few days after birth. The main symptom after birth is going to be unconsciousness. Unfortunately, there is no cure for anencephaly. Treatment does aim at making the baby as comfortable as possible until death occurs. And now your post-test.